conclusion that workforce is one of the like absolute key pillars to being able to improve birth outcomes in Oregon. So I'm thrilled to be able to talk to you. Next slide. So as I said, I work for the Oregon Perinatal Collaborative. I'm the executive director. The Oregon Perinatal Collaborative is Oregon's perinatal quality collaborative, and every state in the US has a perinatal quality collaborative or PQC. And the PQC's job is to look at all the births in the state. That's about 39,000 births in Oregon a year, and to look at where we have problems with safety, quality of care, respectful care in our state, and then to make initiatives and other programs to improve evidence-based care, respectful care, to close gaps in care, and to advance policy to improve maternal and infant health. So we work with hospitals, healthcare providers, nurses, the Oregon Health Authority, doulas, a number of community-based organizations, home visiting programs, and more to work on a wide range of topics that are kind of like the drivers of problems in maternal and infant health in Oregon. Most recently, we've been working on severe hypertension and preeclampsia and hemorrhage and newborn resuscitation, and soon we'll be starting a program on perinatal substance use disorders. Next slide. So I probably already covered a little bit of this. We work with a whole network of partners in Oregon and nationally because we're trying to touch on every part of the maternal health and infant health workforce and all of these different places where people who are pregnant or postpartum encounter or receive care. Next slide. And we work on maternal health for a lot of reasons, but one of the main reasons that we work on maternal health, and one of the reasons why I really wanted to talk to you all about maternal health, is that maternal health is central to community health. It's hard to have a healthy community or health across the life cycle if we don't support pregnant mothers and pregnant people. And I think it should be a priority for OHA and for the OHA workforce committee for that reason. I tried to kind of represent this here where if we fully support pregnant mothers and pregnant people, then we see these, kind of immediate term outcomes like an increase in breastfeeding, decreased preterm birth, decreased infant mortality, less adverse childhood events. But then those lead to these major impacts over the life cycle, like less chronic disease, reduced healthcare costs, less addiction, fewer children in foster care, and more people accessing preventative health care. So maternal health is this kind of center of and beginning of health in the community and health throughout the whole life cycle. Next slide. The other reason why maternal health is so important in a health system is that investments in the prenatal period and the first year of life are by far the most cost-effective investments that we can make. You can see this is Heckman's curve, but those prenatal investments and investments in the first year of life just have so much greater return on investment than later interventions. Next slide. So I wanted to talk about the maternal health system in Oregon. And as you can see in the way we've done this illustration, maternal health isn't just about doctors, nurses, clinics, and hospitals, but it's related to any and all type of support that a pregnant person might need during their pregnancy, birth, or the postpartum period to have their basic needs met and to be physically, socially, and emotionally healthy. And this can help us like look at maternal health in a broader way. In some ways, the basic supports around housing, around food, around transportation, around mental health services can be even more central to maternal health than access to prenatal care. I'm trying to think if there's anything else I want to say about this slide. You can also see how vulnerable maternal health is in this current environment of cuts to funding for a number of these different kinds of programs at the federal level. Next slide. So I first just wanted to go through this a little bit more expansive view of what the maternal health workforce roles are. So I've got a few different slides about that. And the first slide is what we think of as kind of like the core traditional maternal health workforce roles. And nurses are at the very center of that. Not just labor trained nurses who work in labor and delivery units and family birth centers in hospitals, but also newborn nurses and NICU nurses in larger hospitals where those are divided up, and then home visiting and public health nurses. And then we have physicians, and in some parts of the state, most of the physicians caring for people in pregnancy, birth, and postpartum are OBGYNs or maternal fetal medicine specialists, but in many rural areas of our state, those are also family practice physicians with training in obstetrics. So they do, full lifespan family practice as well as caring for people in pregnancy, birth, and postpartum. Then we also have midwives, certified nurse midwives who mainly work in the hospital and clinic, but also a small number of them work in birth centers and home births. And then certified professional midwives who are licensed in Oregon as licensed direct entry midwives who work in birth centers and home births. We have doulas, community health workers, peer support specialists who are all providing more of that like social, emotional, and direct physical support. Doula specifically providing direct physical support during labor, and then also acting as kind of connectors and access points to the rest of the healthcare system and to the kind of social supports that a person might need. There are also a range of lactation professionals offering support around lactation, and then home visitors. So these are the kind of core maternal health workforce roles that are providing that direct care during pregnancy, birth, and postpartum, caring for the pregnancy, caring for the like physical and social health of the person during that. And as we'll talk about later, there's some significant shortages in many parts of this workforce. But then next slide. There are also a really huge role for the behavioral health workforce related to maternal health. In Oregon, our leading cause of maternal mortality are maternal mental health issues, including substance use disorders. And so this behavioral health workforce, everyone from peer support specialists to psychiatric providers, social workers, counselors, substance use disorder treatment professionals, including residential treatment, and domestic violence workers are essential to maternal health. And Oregon rates 42nd in the US for composite scores around like how people are doing mental health wise and mental health access across the state. So this is an area where we have pretty significant problems in access. Next slide. And then I also just want to highlight that there are a whole other category of workers who are very much, to me, part of the maternal health workforce. These are areas where they help Oregonians meet their basic needs, and it's essential that this workforce is robust for maternal health. So that is workers in DHS, in OHA, in various ways related to OHP, in CCOs, related to SNAP, to food banks, to transportation, and to 211. So I just wanted to kind of do that step back and think about everyone who's in the maternal health workforce so that we weren't just thinking, oh, it's doctors and nurses, because the maternal health workforce is pretty expansive and needs to be expansive to like support the complex needs of pregnant mothers and pregnant people. But I also wanted to just pause and let anyone answer in the comment or out loud if you feel like there's anyone else who's missing from the maternal health workforce. Maybe I covered it all, but I just wanted to stop because okay, community health workers, yes, they were listed on I listed them on that very first slide because they are centrally important. They're part of the core workforce here. Yeah. And especially so important for helping folks in specific cultural, and it's okay. Um, no worries. I said a lot of things, so it makes sense that they might have gotten missed. But the community health workers can be so important, especially for specific cultural and language communities who have, more barriers than usual in accessing care and health systems. Someone else was saying in the chat, legal support services. Yes, I love that. That's a great addition. This can be a time when there are a range of legal issues coming up that someone might need support around to support a like healthy pregnancy, birth, postpartum experience. All right, next slide. So the other thing I wanted to talk about, and this slide is so rich. This was a map that was made for us from by Emerson Ong of the Office of Rural Health, and it looks at all of the birthing hospitals in Oregon. And it's useful to think about in terms of understanding the workforce because we have 46, when this map was made, we had 47 birthing hospitals in Oregon, but the birthing services at Providence Seaside have closed since then. And all of those hospitals, every one of those hospitals needs to maintain, so each of those blue numbers across the state is a hospital and the number of births they do a year. And each of those hospitals needs to maintain a full workforce of labor trained nurses, delivering providers that could be physicians or midwives. They need to maintain respiratory therapists and support staff. And so that is, a pretty big task across the state. And especially in rural areas, maintaining that staffing. You can also see that there are areas of the state, all of the red counties where the county is named in red, don't have birthing services in their county at all. So then you're also seeing people are traveling some significant distances to give birth. Next slide. So I wanted to talk about who attends births in Oregon because that's a core part of understanding the maternal health workforce. Um, about 70% of births in Oregon are attended by physicians, but there's a big data gap in Oregon and nationally where it's not recorded whether when a birth is attended by a physician, it's not recorded whether it's attended by an OBGYN or by a family practice doctor. And family medicine doctors are a huge part of the workforce for birth care in rural Oregon, but we don't actually have information about what percentage of those births they're attending. And that makes it really hard to understand how many family practice physicians we need and how many obstetricians we need in Oregon. It gets really hard to parse that out. But then we can see that 24% of births are attended by certified nurse midwives in the hospital, and then 5% of births are planned community births in the home or birth center setting. The majority of those are attended by certified professional midwives who are licensed in Oregon as licensed direct entry midwives, but there are also a significant number that are attended by certified nurse midwives and a small number that are attended by naturopathic physicians who have a special credential to attend births in Oregon. So there's a kind of range in the workforce there, and we need more of all birth providers in Oregon. Next slide. So I wanted to highlight some recommendations that came out of the Oregon Maternal Mortality Review Committee, of which I'm a member. The Oregon Maternal Mortality and Morbidity Review Committee reviews every maternal death within a year of birth in Oregon, and then looks at those that are related to the pregnancy, where the pregnancy could have been a contributing factor to the death, and thinks about, you know, was this preventable? If it was preventable, what needs to change um, in patient care, in systems, in policy to support better health in pregnancy, birth, and postpartum? And I'm going to go through all of the recommendations because all of them are workforce related to me. They are workforce related in different ways, but they all touch on workforce issues. Sometimes it's education for the workforce, sometimes it's increasing particular parts of the workforce, sometimes it's making sure that different parts of the workforce are actually in communication with each other and not siloed. So, in these reviews of maternal deaths in Oregon, the committee has made these recommendations. One, that all payers, including Medicaid, should prioritize coordinated mental health and substance use disorder care for pregnant people. And this is a workforce issue because we don't have sufficient workforce to do that. There's a whole bunch of other issues around payment and things like that that aren't directly workforce issues, but we don't have enough peer support specialists to support this need. And we know that peer support specialists are kind of core to providing excellent care for pregnant and postpartum people with substance use disorders. We don't have enough obstetric providers, including family practice physicians and certified nurse midwives, who really have the training that they need in substance use disorders, or who have gone through the training to be able to provide medication assisted treatment. We don't have enough behavioral health providers who have specific training in maternal mental health, and understand how to um, have understanding about lactation and medications or things like that. And we don't have enough substance use disorder treatment workers who are skilled in working with people in the pregnancy and postpartum. We have many, many treatment resources in Oregon that aren't open to pregnant and postpartum folks. So then the second recommendation is systems need to support improved communication between care teams across medical specialties and disciplines. And to me, this is a workforce issue because so often each workforce is completely separate. The professional organizations, the statutes, the structures within a hospital, the structures within a health system, the structures within a clinic often keep them siloed. And there's this big leap that we need to make conceptually in thinking of like integrated workforce, where the different parts of the workforce, like the workforce isn't functional if the different parts of the workforce don't see each other and communicate with each other. The third one is care teams need implicit bias training and support. And to me, this is a workforce issue because it's just thinking about the high need of the whole patient population for unbiased, respectful care that meets them where they're at, and that each of those workforces that touches on pregnancy care needs to be supported in being able to provide that care. The fourth recommendation is strengthening postpartum support systems. And that's a workforce issue because we don't have the workforce. We have this statute that supports universally offered postpartum home visiting in Oregon, but we don't have the workforce to actually pull that off statewide. And we also don't have the funding. We've even seen major long-term home visiting in Multnomah County was defunded this year. That's very successful. So we really don't have the workforce or the funding to do that recommendation. The fifth one is I'm just going to read it. It's a little bit less related. Improve education and support for gun safety, especially in cases with known mental health conditions. And then will you go to the next slide? The sixth is encourage vaccine uptake in underserved communities with culturally specific outreach. And this was really related to some COVID deaths during the earlier in the COVID-19 pandemic. The seventh is increase access to blood products for hemorrhage management and delivery settings. And this especially came up in some rural areas. And to me, this still touches on workforce because there's this whole blood bank workforce and the interaction between the blood bank and each of the rural hospitals and this kind of resource management across the state. And again, it's this place where workforce needs to be so different workforces need to be so connected to be able to see the whole system. The next one is hospitals should implement robust emergency simulation trainings. And this is a workforce issue because especially in smaller and rural hospitals, there aren't always dedicated nurse educator positions. And even when there are nurse educator positions, like I just visited a hospital this past week, and they have one nurse educator among several hospitals, but that nurse educator doesn't have any obstetrics training. And so there's kind of big gaps in the workforce to actually be able to make that happen. The ninth isn't so much a workforce one. And the 10th is improve access to social service and basic supports, food, housing to ensure people entering pregnancy are in a better state of health. There's this workforce issue that is struggling to keep all of those kind of basic support services funded and staffed so that people can meet their basic needs in pregnancy. That was a lot of listing, but I wanted to highlight that because I think often the recommendations that are made about improving the health of a population can look like they're separate from workforce issues, but to me, almost all of them have a workforce element to them and are tied to these like kind of larger workforce issues. So next slide. Another thing that I wanted to talk about in relation to the maternal health workforce in Oregon is in last year, I visited every one of the 47 birthing hospitals in Oregon, and the major theme of the visits was a workforce theme. The number one concern of every birthing hospital in Oregon, besides one, was staffing their labor-trained nurses. We definitely have a nursing shortage. We definitely have a labor-trained nursing shortage. We definitely have a shortage of nurses who have had more experience. There were a lot of nurses who left the workforce in the early COVID-19 pandemic, and many hospitals in Oregon have the majority of their labor and delivery nurses have been in the workforce only a few years. There are also major staffing issues in finding obstetric providers, especially in rural parts of the state, and also major issues in having in-hospital coverage for newborn care through pediatricians or neonatal nurse practitioners or family practice physicians. Another major theme of those visits was that there was worsening health of pregnant mothers across the state, both with chronic health conditions and complex social and behavioral health needs. And it just means that the whole workforce is needing to step up their level of care, and the work that they're doing is taking more time and more resources than ever before without any change in payment. So we're still in the same kind of payment structure that we've been in for a really long time, that was built on a much simpler model and a much healthier population. And that's supposed to pay now for really complex pregnancy care. And that is putting a real squeeze on on hospital systems and the workforce. You can read this whole report on our website, and the QR code for that is there. Next slide. So just to get that into that a little more deeply, we are having some definite maternal health workforce shortages. The most important one is that there is a shortage of experienced and labor-trained nurses. There is heavy competition for hiring nurses and high wages. Um, and um, yeah, there's a lot more to say about that, but in an introductory talk, I'll try to keep it to that. Um, there are also some major shortages in the physician workforce. They look different for in different contexts. It's really challenging for rural hospitals to find obstetricians who are ready to relocate and live in those rural areas and to take a high call schedule. So in a small rural hospital, one obstetrician needs to cover more call time because births can happen anytime, day or night. They're not scheduled for the most part. Um, what it looks like to be an obstetrician or any kind of OB provider in a small or rural hospital is really different than how it looks in a really large volume or urban hospital. So there's a kind of dwindling number of obstetricians who are willing to take those positions. Um, there are few practice physicians practicing OB. And that model of family medicine is really what is most functional for our smallest rural hospitals because there's too small of a number of births to support an OB practice. So they need a physician that both does other kinds of care and births when births present, but there are fewer and fewer family practice physicians who are practicing OB. And then there's a kind of dwindling number of newborn providers willing to take hospital call in rural areas. Um, there's also some workforce shortage among nurse midwives who are really needed and would go a long way towards improving outcomes in our state. And then there's a pretty extreme limitations around access to psychiatric providers and social workers. That's one of the things that we talked about with hospitals when we went on these visits around the state. And there were a number of areas of the state where local access to psychiatric prescribing providers was pretty much non-existent. Um, and even when there was distance access, it was very long waits or only being able to access in an absolute emergency, which means that the physicians and nurse midwives are often managing um, patients with complex mental health diagnoses that feel like at the very edge of their scope of practice or even beyond their scope of practice. And then access to licensed clinical social workers and other therapists is really, really limited. I don't think there's anywhere that we visited that even when they had a pregnant patient or a postpartum patient with a significant need, like say someone with, you know, new worsening postpartum depression, I don't think there was anywhere where the wait to get in to see someone was less than 1 to 2 months. And in many parts of the state, the wait was 3, 4, 5, 6 months. Which, if you have any understanding of maternal mental health challenges, is unacceptable. When someone presents with like a new mental health challenge in pregnancy or postpartum, that's a time when they need fairly immediate support. Next slide. Um, Rural areas of our state have their own really particular workforce challenges. They're expending a lot of energy on recruitment and retention of nurses and providers without a huge amount of return on the labor that they're putting in, even though they're getting there's some pretty amazing support that's available through the Office of Rural Health and some um, other organizations in Oregon. This means that a lot of the rural hospitals are having to resort to the high cost use of locums. So those are physicians that just come in for a short period of time. And the use of locums isn't just high cost, it's also low safety because the locums are not invested in the same way in the local community and are not part of the kind of like ongoing training or quality improvement work that's happening at the local level. So they're often not as trying to think of a way to say this. They're not as beholden to the expectations and to the standards that that hospital or that is working on as someone who's there long term. Our rural hospitals are having some special challenges in maintaining emergency skills with low birth volumes. So every hospital that does births has to be able to address any emergency that comes in their doors and have skills to do that. But it's hard to maintain that when you have a really low number of births. And hospitals really clearly said that there was a need for statewide simulation support to support the workforce in maintaining their skills. That's not something that exists in writ large currently. There are some smaller programs through the Office of Rural Health and through OHA that have offered support for that for some hospitals sometime, but there needs to be more of a broad support. And that's something that the Oregon Perinatal Collaborative is seeking funding to develop a statewide mobile simulation program. The inadequate reimbursement for obstetric care is especially hard on rural hospitals, and it makes it very challenging for that they're not paid enough to actually staff their labor and delivery units at the level that they need to provide safe care. And then there are some parts of the state, especially we heard from some coastal areas and in the Columbia Gorge, where housing shortages are really impacting recruitment because it's hard for someone who was going to move to the area to find affordable housing. Next slide. The current federal cuts and policy challenges are going to have and have already had some impacts on the maternal health workforce. We've already seen that there is this 15% cut to federal Medicaid spending and 186 billion cut to SNAP over the next 10 years. And both of those things will have big impacts on maternal health, and the Medicaid spending one will have a big impact on the maternal health workforce. And it actually just remains to be seen through which pathway the impact will happen, because there'll be decisions that need to be made at the state level about how to respond to those cuts. There's also a big impact on the workforce that is doing Medicaid and SNAP determinations and redeterminations, because there's increased administrative burden, and so that's an impact on the workforce there. The thing that I'm the most worried about are these last three things that will really compound the physician shortages that we're already experiencing. So there have been restrictions to the public student loan forgiveness program, this lifetime cap of $200,000 for federal student loans, and the $100,000 cost for H-1B visa fees. And all of those things will make less people become physicians, less physicians work in rural areas, and will mean that we have less international medical students and international physicians coming to the US. And especially in rural areas of the state, those international medical students and international physicians are a huge part of filling those roles. So this has just set up a new barrier that will have a big impact there. Next slide. There are a lot of policy changes that could support the maternal health workforce. The Keeping Obstetrics Local Act that was introduced by Senator Wyden is one of the most important. It looks at a number of different policy levers that could support the maternal health workforce and reimbursement to keep rural and small labor and delivery units open. We need ongoing robust Medicaid funding to have a robust maternal health workforce. We need continued funding of perinatal quality collaboratives and maternal health programs within HRSA and CDC. We would need restoration of the funding for the pregnancy risk assessment monitoring system, which was a big kind of like safety program within maternal health. At the state level, we do need investments in perinatal and behavioral health workforce. To me, the priorities are nurses, family practice doctors, and midwives, and especially um, it seems like we probably need another nursing program in Oregon. I've been excited when there's been talk of starting another program in Roseburg, um, or was it Grants Pass? I'm going to get that wrong right now, so don't rely on my information to be reliable there. It would be great if there was a funded OB fellowship for family practice physicians. Um, we also need investments in the expansion of Nurture Oregon, which are the programs that provide um, wraparound behavioral and medical care for pregnant and postpartum people with substance use disorders. And we really need payment reform for how we pay for pregnancy, birth, and postpartum care as population health declines and care gets more complex. Next. We can also have policy change for maternal health at the county and hospital or clinic level. Counties can make maternal health a priority in their planning and view it as kind of central to thinking about community health. Some counties have already created or are in the process of creating local maternal or perinatal health task force that can be useful for developing connections and maintaining that focus. And then hospitals and clinics can create or preserve practice support, quality improvement, and education positions that support their labor and delivery units. They can provide protected time for quality improvement and education in perinatal health, and they can support opportunities for collaboration between clinics, hospitals, and hospital systems because some of the larger hospitals have some resources that could really benefit smaller hospitals if they were in more collaboration. Next slide. We had a big attempt at passing some maternal health and infant health supporting bills in Oregon in the 2025 legislative session. Two of those bills passed, and one of them, Senate Bill 692, was really related to workforce that increases access to doulas and lactation services. And so that was a huge impact for the maternal health workforce. Unfortunately, Senate Bill 693, which would have created a perinatal workforce committee to really look at the maternal and infant health workforce statewide, did not pass. And that's something that's really, in my opinion, needed. I think we need a place to think about all of this workforce together. Next slide. So I think we have a lot of opportunities right now in Oregon. There is some increasing focus on maternal health and infant health from leaders in Oregon within the legislature, within the governor's office, within OHA. There's interest in preventing maternity or care deserts. There's some openings for meaningful policy change. There's been progress on perinatal substance use disorder payment reform. So I'm hoping that people who are interested in this might get involved. And I wanted to just announce that we are planning a 2026 maternity care deserts convening, and we'll be reaching out to a number of partners to think about planning that together to try to do some coordinated work thinking about maternity care deserts, which are absolutely nearly a total overlap with the maternal health workforce issue. So that's all the information I was going to present. The next slide is just a questions slide. So let's stop sharing slides and then open it up to questions and discussion. It's nice to see some people that I know or have met here.
I had a question to get us started, if that's okay. I know that I've heard that there's a significant disparity gap among racial groups with mortality rates in the US. Is that, can you talk a little bit more about that and also if that disparity exists in Oregon?
Yeah, yeah. In the US, we have some really significant racial and ethnic disparities in maternal and infant health outcomes, most notably for most notably nationally for Black or African American folks and for Alaska Native or Native American folks. And that isn't related to anything inherent about Black bodies or Native bodies. It's about kind of structural and interpersonal racism that impacts, social determinants of health and access to care, and then bias in care that people receive. In Oregon, our main disparities are related to Native American, Pacific Islander, and Black or African American groups. Um, so we definitely have that as well in Oregon. It's harder for us to track because we have smaller numbers, and luckily, maternal mortality is a rare event. So it takes a long time to get numbers that are significant, but we do know that Pacific Islander, American Indian, and Alaska Native, and Black or African American folks are having disproportionately poor outcomes.
Thank you.
Delina, go ahead and let me know if I said that correctly.
Yes, you did. Thank you so much. Thank you for all the information. It was absolutely great. I was wondering if you had any idea with the Medicaid cuts, what the impacts will be on specifically like maternal healthcare wards. I know I've been hearing a lot about some of the coastal hospitals ha possibly having to shut down their maternity wards. So I'm curious if you had either a range or even like a specific geographic area that would specifically be the most impacted by these cuts to Medicaid.
Yeah, yeah. So this is such a complex issue in part because we don't know how Oregon will respond to those cuts yet. Like the state is going to be in a really hard position of needing to deal with that reduction in funding in some way. And that could be like decreasing the number of people who are covered by OHP or decreasing rates or decreasing what is covered and or a combination of those things. And all of those things could have different impacts in different ways. So if rates are reduced around maternity care, that will be devastating because they're already inadequate. Like already, like for example, I did my own billing for a long time as a midwife, and but there's a lot of time that you're operating at a loss when you are covering a Medicaid patient for the course of pregnancy, birth, postpartum, depending on how it goes. So that would really, really make it hard for our smallest rural hospitals to stay open. Um, the other thing that would have an impact is if less people are covered, then it will mean that there are more patients who are uninsured, and then hospitals, clinics, providers will have more unpaid care. So it will like increase the amount of, unpaid bills that any hospital is giving. And then that again impacts the smallest hospitals and the rural hospitals the hardest. But I think there's still so much to be determined about how that's going to go. When that bill came through or when it was being debated, Senator Merkley and someone else put out a report about hospitals that were kind of like would be the most vulnerable to closure with those changes. And that was an interesting resource too, because that looked at mapping. It was interesting to look at the hospitals that they had slated at being most at risk for closure in Oregon, because I have significantly more that I'm worried about than were listed in that report. Eric, go ahead.
There's a mute button. Yeah, and I would say I was just going to add to that, not necessarily add a question like that. The report on which hospitals were in particularly vulnerable, and since we don't know whether they're going to cut rates or cut coverage, and they don't know either, on how this is going to happen is that there's a couple of hospitals that are particularly like I think every hospital is vulnerable. Like that's let's just be honest with that, that every hospital who delivers anybody who's on Medicaid is vulnerable. But there are a couple hospitals in particular that have a high percentage of maternity care as part of their business model. And there's also a high percentage of Medicaid or uninsured folks in those communities. And so when you look at Merkley's kind of that I think there are three hospitals at least that jumped out to me because they do a lot of deliveries and a lot of Medicaid deliveries. And those things were listed like, Silverton, 80% of their admissions are deliveries. And since they are close to Woodburn and have cooperative relationships with like Yakima Valley Farm Workers and other clinics that serve the Mid-Willamette Valley, like that's why that one's more vulnerable. St. Charles and Madras is right close to Warm Springs, and that is a majority minority town. So they have again a lot of migrant farm workers, uninsurable people, a lot of Medicaid, and close to high risk folks. And so that one was on Merkley's list. And same thing with Hood River. Like all three of those jumped out to me as like they do a lot of deliveries, a lot of Medicaid deliveries, and take care of vulnerable populations already. And those were like the ones that are both near and dear to my heart and most disappointing to see on there. But I think depends
Yeah.
on how those cuts are implemented. Every hospital could be at risk.
Yeah. Thanks for adding that, Eric. That's all of that and insight is really useful. I'm gonna read a couple things in the chat. Elena's saying, I'm wondering if there are other states that have had success in improving pregnancy access and or workforce, and if so, what strategies they employed. So this is a current struggle across the US. There's a really good March of Dimes report about maternity care deserts and access to maternity care. And you can see in that relative to other states, Oregon is actually doing significantly better than a lot of southern states, especially. Um, so there are a lot of ideas about innovation, but not a huge number of things that I would say this is a great successful model. Some things that have been piloted that are the most successful are some kind of capacity payments to our smallest rural hospitals in recognition that they don't do enough deliveries to cover the cost, but that it's a value to the state for them to stay open. So those capacity payments are useful. And then, why is my mind blanking? There are a number, if you look at the Keeping Obstetrics Local Act, there are a number of the kind of most forward-thinking policy solutions in that bill right now. Um, and I can think about that and loop back because I know I have other information about that. I'm just not thinking of right now. And then Delina's asking, is OPC a part of any Medicaid work groups possibly being formed by the governor's office or the state legislature? And currently we're not, but we would love to be. Anytime we're thinking about maternal or infant health for the whole state, we would love to be at the table because we're really connected and have a lot of experience thinking about this stuff. And there are some great people. The other thing I would say to that question, Elena, is that there are some great folks thinking about this within OHA who I know are mapping a bunch of potential solutions. Lizzie, I don't know actually how you pronounce her last name, Fussel, and Katie Maynard, I know are doing a lot of mapping about like all of the potential approaches and policy solutions around maternity care deserts in Oregon and would be great contacts for those of you, especially in OHA, if you want to learn more about the kind of like thinking and strategizing that's going on.
I also really liked your presentation. Thank you. I'm Laura. I'm a fourth year med student at OHSU, actually applying into family medicine. I am not a huge OB fan myself, but I've been amazed that there's so many of my classmates and people that I've met along rotations in other states that love OB and that have switched from like wanting to specialize or wanting to go into OB to family medicine with an OB focus. And I really appreciated kind of your mention about kind of expanding OB fellowships for family medicine. I'd also love to see like combined programs. I think there's a lot of excitement among students for those kinds of things, but there are not a lot of programs out there that offer like the 4-year family medicine OB integrated residency.
Thanks for sharing that, Laura. And I love it makes me so happy to know that there are current family medicine students who are interested in OB because I get scared that it's like that the numbers are just going to keep dwindling when I look at the whole state, like we can't do rural we can't do rural maternity care without family practice OBs. Anything else while I'm here?
Um,
Go ahead, Deepti.
I had a quick question. You had mentioned there was a pie chart that you had shared earlier in the presentation about who's present at births, and
Hmm.
that there's not data on the type of physician that's there.
Hmm.
Is there a reason why that's hard to collect? It seems like an obvious thing, and I'm just wondering what the challenges are to collect that.
I don't know why it's not collected. There's a lot birth certificate data, which is where that would be collected in the US, is really fascinating. And it's just like completely piecemeal state by state. There are some things that like are mandated that have to be collected by every state. Like for instance, in Oregon, we're literally the only state that collects accurate data on planned home births and birth center births, where you can actually differentiate between planned and unplanned community births by provider type. So you can look at the outcomes between licensed providers and when someone has an unassisted home birth. And then it's that way with so many other things in birth certificates as well. So I think it's a historical vestige. No one thought it was important data at some point when it was included, and then it hasn't been changed. The category is just MDDO on the birth certificate um, currently. So it would require I don't know. Other birth certificate changes that I'm aware of have required a statute change and some funding for the change because then it has to be education that goes out to um, every registrar who fills out birth certificates across the state, which is a lot of people. But I don't know if that's the only pathway for birth certificate changes to be made. That's just the changes that I'm aware of. That's how they were made.
I'm also like afraid of that attendant data that fails to recognize the call and the collaborative work that's being done. So like just because like a delivery is done by a family physician or a nurse midwife, it doesn't mean there wasn't a OB/GYN available for a C-section. Or
Yeah.
the other way around. So like the fact that we were often delivering folks in multidisciplinary teams, like
Yeah.
boiling it down to a binary thing that this one person was there to catch the baby, like I think will underestimate or misrepresent the workforce that's involved.
For sure. And it's also interesting because in a lot of rural areas, someone might be receiving their prenatal care from a family practice OB, but then they risk out of delivering at that hospital and they deliver at a larger hospital. And the only thing that's recorded is who they deliver with. But knowing who the delivering provider is also fairly useful for outcomes because, like, nurse midwives have really different outcomes than obstetricians, a way lower cesarean section rate, higher breastfeeding rate, other things like that. And it's useful to be able to track that because we're in still kind of like a structure where we historically think everyone needs an OB, but that's not the case in any other developed country in the world. Like the kind of most effective model is that low risk folks are cared for by the majority of pregnancies. Low risk folks are cared for by midwives and family practice physicians. And then we reserve the really specialized skill set that obstetricians have that's so important for when they're needed for complications and surgeries. Well, thank you all so much for having me. I know we're at time and I don't want to keep you over. I really appreciate the opportunity. And um, I think, I can't remember if maybe I didn't put my contact information in the slides, but I'm very easy to find on the Oregon Perinatal Collaborative website and love to be in touch to talk with people about workforce issues and especially policy change to support the maternal health workforce. Um, so good to be with you all, and thank you for having me.